very much, Judy. Right, order. Welcome to the Public Accounts Committee on Monday the 12th of January 2026, and a Happy New Year to everybody. Independent hospices are charities that play a key role in the local and national healthcare systems as they provide palliative and end of care to local communities across the UK. Currently, there are 135 independent adult hospice charities in England, as well as 2 national charities, Marie Curie and Sue Ryder, which operate across England. In 23-4, the independent adult hospice sector provided around 251,000 people with palliative and end-of-life care. The majority of independent adult hospices' income is generated through charitable donations, fundraising, legacy gifts from wills and retail activity. The second largest source of funding for hospices comes from the government funding, including from the NHS via integrated care boards. Many adult hospices have recently reported increasing financial pressures and the threat of needing to cut services unless additional funding is sourced. This comes at a time of increasing demand for palliative care due to the UK's ageing population. So today, we are fortunate to have with us a panel of witnesses with a huge wealth of knowledge and experience working in this sector, ahead of questioning from senior government officials later this afternoon. So we hope to hear from all of you what you think should be done to guarantee the financial sustainability of adult hospices in England going forward. I'd also like to make it clear from the outset, this hearing is that we are not going to stray into the debate on assisted dying, as is not the purpose of this inquiry. So we're very warm welcome to the Right Honourable Baroness Finlay, Professor Fliss Murtagh, and Toby Porter, and I'd ask you, each of you, just to introduce yourselves and say something briefly about your experience in this field. So would you like to start, Baroness, please?
Thank you. Well, I'm a crossbench peer in the House of Lords. I'm also a Professor of Palliative Medicine at Cardiff University. In 2008, I had responsibility for implementing the palliative care strategy in Wales. I could say a lot more. I think my colleague, Fliss Murtagh, is the person who's got all the data to hand, which is really important for your committee. So I'm not going to take more time. I'll give a little bit of time to her.
Thank you very much. And have I got, we will normally sort of refer to each other in their Christian names. Elora, is that correct?
I'm Elora, and please use my first name. Thank you.
Great, well, good to have you. Professor Fliss Murtagh, please.
Thank you. I'm Fliss. I'm an independent expert, and I have no charity affiliations. I'm a doctor by background. I've been a GP for nearly 10 years, and then I've been a palliative medicine consultant for nearly 20 years, working across all settings, including hospices, but also hospitals. I lead a palliative care research group of about 40 researchers, which is about the second or third largest group in the UK. And I'm an NIHR senior investigator, which is a small number of people awarded for their work in applied health and social research by the NIHR.
Thank you. Toby Porter, please.
Good afternoon, I'm Toby. I'm Chief Executive with Hospice UK. Hospice UK is the membership body that represents the UK's adult and children hospice sector. I've held the position for 3 years, and prior to that I was Chief Executive of a children's hospice in the West Midlands for 6 years.
We're very pleased to have you. Thank you very much, Toby.
Jeffrey, forgive me, I should have declared that I'm Vice President, Honorary Vice President, Hospice UK of Marie Curie, and a patron of various hospices.
Thank you for that. Any other declarations from either of you? No. All right. And in addition to you three, who we're very, very pleased to have, you're all very experienced people in this field, I'd also like to extend a warm welcome to our guest member for this session, Paulette Hamilton, who is a member of the Health and Social Care Committee and was at their hearing last Wednesday. So let us move on and start the questioning, if I may, please. And to start us off with that, please can I call on Anna Dixon.
Thank you very much, Chair. Good afternoon, panel. Before I get into questioning, I would also like to just draw attention to my register of interests. I'm a member of the APPG on hospice and end-of-life care, and I have done paid work before becoming an MP, supporting King's College London on setting up of an impact centre on palliative and end-of-life care. It's now over a decade since the Ambitions National Framework for Local Action on Palliative and End-of-Life Care was published. In the government's vision for palliative and end-of-life care, it is that every person who needs it should receive high-quality, compassionate palliative and end-of-life care. I'd like to start by asking how close you think we are in realising that ambition. Who would like to go first?
Yeah,
please?
may I take that question? I should also have mentioned that I'm the co-lead of the NIHR-funded Policy Research Unit in Palliative Care, which I forgot.
Thank you.
So can I start with 3 points of language before I answer your question? The hospice sector is about the beds, but more importantly about the huge amount of community services and support for people at home and the training that the hospice sector provides. When we talk about specialist palliative care, it's the hospice sector plus hospital specialist palliative care teams who are the Cinderella services who go under the radar. And I think for the purposes of your considerations, it's really important to think about a system-wide approach, because any solutions which are not system-wide are not likely to work. End-of-life care, in my view, is a pretty meaningless term. If you say it to health professionals, they usually think of the last few days of life for someone. If NHS England are asked, it's the last year of life. The trouble with that is most people are not identified anything like the last year. So it's a retrospective understanding. I would say, in answer to your question, no, and it's getting worse. That's the short answer. I can tell you that there used to be a Voices survey which was commissioned from the Office of National Statistics from 2011 to 2015. And it was a post-bereavement survey run nationally to find the answer to your question. It was stopped in 2015, and that's a real omission because we now haven't got the evidence to say what the quality of palliative and end-of-life care is like. Marie Curie had the vision to fund work, which myself and Catherine Sleeman led, and in a smaller scale level, we repeated that post-bereavement survey, and the report is 2024, and it's the best recent evidence we've got. 1 in 5 families of these people in a nationally representative sample said poor or very poor care from the GPs in the last 3 months of life. 1 in 5. Now that compares with 12% in 2015, so it's got worse. Okay. And we also know that they reported a similar worse view of the care from hospital doctors. 14%, so 1 in 7, said poor or very poor care from hospital doctors, and that was notably worse than the 9% in 2015.
So given that, the answer being basically no, not meeting that ambition for what sounds like a large minority of patients and families from that survey, what do you think are the main issues, therefore, that the government must now address, Elora?
Well, I would just say we know what to do, but we're just not doing it. And when we ran the inquiry, the Commission on Palliative Care, that came out loud and clear. So people can think about different types and schemes, but basically patients and families are just not getting the care that they need, and there is inadequate education and training right the way through, from early on right through all postgraduate training, and there is a risk aversion, I fear, that has come in amongst some healthcare professionals, which means that in fact they're being less imaginative for the individual patient and the individual family. But also, if you don't have 24/7 services, you're going to miss out on when the crises happen, when people are really needed. 75% of the week is out of hours. And without 24/7 services, you're actually not going to be there. And it will just be too little too late.
The evidence we've received in the NAA report set out many factors: money, workforce shortages, lack of strategic sort of commissioning.
Yes.
So what would you highlight as the sort of main challenge in achieving that ambition?
If you don't commission against outcomes and you only commission based on activity, you're not going to drive up the improvement in outcomes that's necessary. And I think in a nutshell, there are measures of outcomes. In our own cancer centre, we use them, really simple, IPOS scale, and we're able to show improvement. So even though the disease progression is happening and people are deteriorating, you can show where you've got specialist palliative care coming in at the right time that you can actually improve quality of life. But if you haven't got the team there, you can't do it.
If I can pick up one of those points, over time, specialist palliative care has been coming in later and later and later. And we have shown in a very robust systematic review that you need about 3 months at least to get the impact across. And we now know that people are getting specialist palliative care only in the last 2 months of life, and if you've got a non-cancer condition, only in the last month of life. So we hear from the professionals again and again, and from patients and families, it was all too little too late. And the pressures on the hospice sector have been such that they've had to retrench when the need is increasing.
Yeah, I'm sure we'll hear more from Toby in due course,
Yes.
but I'll hand on.
I'm going to go to Catherine in a minute, but I just am keen to pick up, Professor Fliss, on your point about the perception, at least, of deteriorating services provided by the primary care, by the GP. Why you think that is? Is it because of their workload, or what is the problem?
Okay, so we have done modelling work to show where the formal healthcare costs go in last year of life for all people who die. And that's all people who die, regardless of whether they've had generalist palliative care from their GPs and district nurses, or whether they've had specialist palliative care, or whether they've had none of it. And that shows about £22,000 is spent per death. That's the average. Obviously, some people will have a huge amount more and some a huge amount less. But most of that, 78% of it, goes to the acute hospital sector. And a pittance goes to any of the other partners. And the other partners in formal healthcare, the ambulance service, district and community nursing, about £800 per death. Specialist palliative care provided by the hospice sector, about £1,000 a death. And so on and so forth. Even the GP sector is only between £1,000 and £2,000 per person. So you can see the flow to the acute sector is a problem. The other big problem, two big problems, I don't think the Department of Health or NHS England know how much hospital specialist palliative care is available. They are tiny teams and they've all been seeing huge volumes. Now, if those teams could work in the hospital to identify and support people, get them out earlier, prevent readmissions, and they could be in the ED department and they could be liaising with the hospice sector more closely, they would give a wonderful return on investment. And we have shown in the modelling that for every death in hospital, specialist palliative care saves the NHS £6,500 per death. And if it's in the home, specialist palliative care saves £8,000 per death. Now that's the current situation. If there was a upfront investment to make sure we had better specialist palliative care teams in the hospitals, they're a tiny resource, they won't cost you that much. And if we had the appropriate community services, including proper out of hours and including more time allowed for GPs to actually get to see people, then we would work towards a solution that would save money. The second problem is the culture in hospitals is to treat people. And we found in our survey, and this is evidence, this is not hearsay, this is evidence, 40% of the families of all the expected deaths told us there had been no conversation with the person in the family who died about possible deterioration, possible approaching death. 20% of families had no conversation at all and were completely unprepared for these expected deaths. If the professionals know they're coming, why are the conversations not happening? There needs to be serious illness conversation training mandated for all health professionals. Because if they're not supported to have those conversations in a meaningful and timely way, we will not change the oil tanker from acute to community.
I'm going to ask you later, allied to that, the item on the Today programme from the National Society of Acute Practitioners. But I will come back to that. We'll now move on to Catherine McKinnell, please.
Thank you. So some of the data that you've collected is clearly very interesting, but there are clearly some gaps in that as well. But we know that demand for hospice care in particular is increasing, and palliative and end-of-life care as well. Do you have a clear idea of what that unmet need is currently?
So for a long time it has been said 1 in 4 of those who need palliative care don't get it. Again, Marie Curie have funded some research which I'm working on with Catherine Sleeman, and I can tell you that now tells us that 1 in 3 of those who might be expected to need palliative care do not get it. And that's regardless of whether you ask the people themselves, have they got symptoms and issues that were not addressed, or whether you look at the access to services that they're not getting. And if you look through both lenses, it's 1 in 3 of those who need. And we've also projected figures for 2050, which shows between 20 to 25% increase in the absolute numbers. So we've got to get this right. I think working out how we get to the solution now is going to be critical.
Yeah. So is that a 20 to 25% increase, you said?
Yeah.
Yeah. Can I just ask?
That is going to be published in March, and
Right.
it's Marie Curie funded.
It's really helpful, and it'd be helpful to know as well, do you have the data? And I appreciate these, assessments have been made and these projections have been made, but is there data that would be helpful to have an even clearer vision on that isn't available currently, that would be helpful to your work?
I think the most urgent thing, in my view, there's lots of data. I think outcomes data would be really helpful, measuring the things that matter to people and families. The hospices can do it. 76% of them are starting to use the core outcome measures. NHS England has done work to look at complexity and currencies with those measures. We just need to get it through faster data flows and actually make it happen and begin to mandate it. And get the data analysts supporting the hospices to do that work.
To ensure it's consistent as
and
well.
To ensure it's
presumably.
consistent. Yeah. And so that would be one thing. I'm sorry, I forgot your question. Can you repeat it?
Well, it was just largely, are we able to measure unmet need, which you have said we have, and I just wanted to know if there is additional data and transparency that would help us be able to identify that.
The question you need to ask is about the hospital teams, because we don't know anything about the hospital specialist palliative care teams. We don't know how many workforce, what full-time equivalent, what disciplines, how many are operating in which hospitals at what bed capacity, are they in ED doing a front door service which says these people actually don't need to come in, and can we support them with the hospice sector to go home and be at home? We don't know that. We don't know much about continuing care funding, and particularly fast-track continuing care funding, and we know very little about social care provision. We've just completed a major study called the Supported Study, which looked at domiciliary home care workers, and it shows they have no training and they have really poor conditions. Is it any wonder we can't find packages to support people at home?
Can I just come in there? Because I think one's got to be clear that you're not talking about one group that have need and the other group don't. They tend to dip in and out. And if people have their needs met early, you can avoid crises later on. So early intervention becomes crucial. And that's where, again, services that link with the local hospice, whichever it is, will allow rapid turnaround. But if the hospice can't manage, you don't have that resource for the early respite, for managing the family that's in emotional crisis as well as the patient who's distressed, where you might be able to get everything sorted out in an hour or two, providing you can break the cycle. So people think that this might be long term, but if you can dip in early, you can avoid that crisis developing. And that's down to the way services are commissioned, and they're not commissioned adequately. They're commissioned in silos, if at all, and they're not commissioned against outcomes. And the one thing that isn't being measured, and I should declare an interest because it comes from Cardiff University, has been family reported outcomes. And there's a simple scale from 16. It takes 2 minutes to complete, but you could actually track from the time of diagnosis what's happening in the family as well, and that becomes important because that family in bereavement will cope better if they've had good care all the way along.
Thank you very much. Sorry, we're now on to Sarah Green, please.
Thank you, Chair. And I should declare an interest that I'm a patron of one of the wonderful hospices that serves our community in Chesham and Amersham. And I know how they would answer this question, but I'm keen to get a national perspective. So if I can ask you, Toby, how you would describe the present state of the independent adult hospice sector in the UK right now?
Yeah, so I can answer that in two parts. So the first part, which I think is really important to begin with, is the state of service. Every day, hospices are supporting about 270,000 people in England. There are 135 local hospice charities. And we're not here for these organisations, we're here for the people they support, the care services they deliver. And we're also here for something broader. If I can just quote something the founder of the modern hospice movement, Dame Cicely Saunders, said: "Approaches to death and dying reveal much of the attitude of society as a whole to the individuals who compose it." And I think all of us are very uncomfortable. I've seen recent coverage, for example, about people dying in corridors and things. We shouldn't accept this. So together, the hospice sector every year provides about 500,000 occupied bed days, 760,000 outpatient appointments, 460,000 specialist palliative care visits, 680,000 generalist visits. It's a huge sector. We're here to talk about statutory contribution to the hospice sector, but can we all just start from the point that the UK charity hospice sector is a huge net contributor and donor effectively to the NHS, in that we raise and spend £1.2 billion a year on care, and 400 million only comes back in statutory funding. So for every pound really raised, for every £2 raised by the hospice, that's given back. So the reason we're here today is because I think really because of 4 years or so of compounding significant cost increases in delivering care, coming up against increased demand for palliative and end-of-life care services because of our ageing population, and very difficult flat statutory budgets at local ICB level, is that the sector would now, not every hospice, but the sector as a whole would consider itself in financial crisis. The National Audit Office report talks about the situation in 23-24, by far the worst year ever for hospices, but the 2 years since have been worse again. And actually the hospice sector is facing a new cliff edge in April, when the period covered by the DHSC's very welcome and useful capital grants programme comes to an end. So it's really and there is a over-reliance on charitable giving, and 2 out of 5 hospices are making cuts. So I know a lot of the constituencies committee members represent, and you know that in your own community. So I hope that answers. Sorry to give you a long answer.
It does, and so you're painting a picture of a sector in financial crisis. And Professor Murtagh said to one of the previous questions that the key is moving the oil tanker from acute to community. So I'm keen to understand, given the context you've just given, what role hospices can play in moving the service from acute to to the community?
Well, I mean, that is our absolute bread and butter. I mean, hospices, I think, are the ultimate in community neighbourhood organisations, that we're not just sort of deeply rooted in our communities, but we operate not just with the consent, but with the active financial support of our local communities. I can honestly say, I visit a hospice almost every week, and almost every hospice CEO I meet, almost every medical director, every director of care, they are always thinking about how they can do more, deliver more care in the community and take the pressure off the acute. Some of the facts that you've learnt for this inquiry, we live and breathe the sort of illogicality of the sector being told there's not enough money to fund their services. And so the very services that would take pressure off the acute, the most expensive part of our system, are being cut back. And therefore people end up in hospital or have longer stays in hospital than is necessary. And it just seems to be a doom loop that continues year by year without logic, and is making the system worse.
It's interesting you call it a doom loop. So it sounds, from what you're saying, like the sector's the independent sector is already trying to help move things to the community.
Yeah, I mean,
just
absolutely.
working in an illogical system.
Absolutely. I mean, the most of the 53% of hospice care services are delivered in a person's place of residence, and only 47% are delivered in a hospice, of which I told you 830,000 outpatient appointments. So often when people think of hospices, they think of the inpatient unit for the very end of life or for symptom management stays, but that only represents 19% in totality of what the hospice sector does. But again, some of our best performing hospices, some of our largest specialist providers have cut the very programs over the last 12 months that are explicitly designed or co-designed not just to bring their humanitarian benefit, but also to deliver more care in the community and to take pressure off the hospitals.
Thank you. I can see Professor Murtagh trying to come in.
You might want some data that would help you with that question. So the hospice sector delivers 665,000 bed days a year. Okay. Now, to give you a context for that, in the NHS, in acute hospitals, there are 30.5 million hospital bed days following unplanned admissions. So I'm not thinking about the planned admissions, it's the unplanned ones, because that's where we need to save. Now, a third of those 30 million are people in the last year of life. If you walk onto an acute medical or surgical ward in any of our hospitals, 1 in 3 people will be in the last year of life. One of the big challenges is that is not recognised by the staff in the hospital. I can't say to a surgeon or a general medic, which are the 1 in 3, because they don't think like that. They think, I've got a battery of interventions, they are hopefully curative or helpful, I'm going to keep giving them. It's what Chris Whitty put into the Chief Medical Officer's report, not last year but the year before. We need to give people less medicine if we're trying to give them better care. Now, because there are not conversations with patients and families about what's happening and the likelihood of deterioration, they carry on having lots of high-cost interventions. And if we could but get those conversations in earlier and get them right, the vast majority of people would not choose to have a lot of things done when there are diminishing returns. But it's that skilled conversation that does not happen. And if of the 40% of expected deaths don't even know the possibility of deterioration or dying, let alone talking about whether an intervention. I mean, dialysis costs over £44,000 a year. There's no funding stream for not giving dialysis. So if the doctors and nurses want to actually say, okay, let's not give you dialysis because it's not going to extend your life, and it probably won't if you're over 75 with multiple conditions, you could give a little bit of funding to get them into that supportive and palliative care pathway, but it's not even funded. So the nephrology teams are left thinking, well, what do we do? Because we don't have that service.
Do you want to come in?
Yes, and thank you for your question, because I think there's another whole dimension to hospices which hasn't been touched on. They are an amazing resource for education. And if they are able to function and can also take, students can take staff, whichever discipline they're on a rotation, they can get educated, so you can raise the standard everywhere. So those medical students or nursing students who go out on placement will learn much more effectively. And the evidence is that you learn because of needing to know. That's the unique teachable moment of, there's the patient, you suddenly realise what you could do and how to do it, and you learn very effectively, and those lessons last much longer than sitting somebody down in a classroom or expecting them to read something or watch some video. So that whole role of hospices as an important reservoir of expertise to their community, and also a source that people can come to get advice. So district nurses who feel a bit stuck, care assistants who want to ask the local, somebody who they know, who's also a carer perhaps working in the hospice, they're safe people to ask. So they will ask, so you can drive up standards of care generally. That isn't counted anywhere, it's not costed anywhere, other than the number of students that walk through the doors. But I think that that's an important resource that is in danger of being lost.
Thank you very much. Thank you, Chair.
Yes, thank you very much, Sarah. Very interesting indeed. Tris, please.
Yes, so I understand this is a question just around the modern service framework. So I know this report was commissioned in October, and I think since this report's commissioning, the Minister, Stephen Kinnock, has delivered that in November. So the question I have is slightly going to be changed because it was clearly pre this report. So my first question is, was the announcement by the Minister, given all of the issues you've just raised and in this report, does it go far enough?
There are two questions in my mind, and I'm very heavily involved. I've been to all the workshops run, and as a policy research unit, we've been asked to provide evidence for interventions under the modern service framework for palliative care. I've been in palliative care since the 80s. We've been in this place before, haven't we? Where framework, strategies, whatever, it's all about what is actually in them and whether it's delivered or not. So it's the monitoring and the delivery of the delivery that is really going to matter. So we can put forward, and we already have done, a host of evidence-based interventions, and I'm sure the Department of Health will select from those and others to make sensible decisions about what might be done. I can tell you what I think are the most hot solutions, if you like. But it's going to be about delivery, and it's going to be about carrot and stick, what's mandated. It's going to be what changes to commissioning are going to happen to make those things happen. And it's going to be reviewing to really see what's changing.
Yes.
Well, I was the person that was behind the amendment to the 2022 Health and Care Act, that palliative care should be a core service for everybody. I had very much wanted it to specify specialist palliative care and had some criteria. They didn't get into the Act. I accepted 80% of what I wanted, but I regret that I didn't push harder, because it is about commissioning for what you want to happen. That's the outcomes. So you can have a fantastic framework and you can set it all out as a strategy, but unless you actually implement it and make it happen, it doesn't happen, because there are so many pressures. And one of the problems, I think, for commissioners is they don't actually know what to commission. So there's a whole deficit of knowledge right across the sector. If you've got a hospice, it needs to be able to get the medication that it needs. Yet we've still got some hospices who are having to buy their own medication, which seems completely appalling. If you have a hospice but there isn't a contract that they can get an anaesthetist to come in and do a quick nerve block that might solve the problem for one patient, that would take half an hour, be quick and simple, then those patients don't get that intervention that will improve their quality of life and outcomes, whether it is for days, whether it's for weeks. But unless you get that commissioning, allowing people to move between the sectors and support that move, you can't get the move of patients either.
Just very briefly, Hospice UK warmly supports the MSF and the work involved, and all of the hospices are participating directly and through us in this process. But we must just, in terms of the specific topic of this inquiry and today's theme about the financial sustainability, what at intervals you'll hear with MSFs that there's no new funding attached. And the thing is that hospices are facing a cliff edge from April, and if there isn't an injection of new funding to help the sector in time for the new financial year, then the boards and chief executives of charities will have no choice over the next month or two to further reduce their services. And therefore we must warmly invest in the MSF and come up with a plan, but we mustn't think that we can just carry on kicking down the track proper local funding of charitable hospices, because another year will mean another significant reduction in capacity and service.
Back on that.
Very briefly.
Just very briefly. So, would you suggest then more long-term funding models? So, in local government, we have a 3-year settlement cycle now. Yeah. And secondly, just lastly, obviously ICBs. In my area, the ICB is supporting the Wisdom Hospice. I'm very lucky. I've got an NHS commissioned service there. This is a postcode lottery around the country. Have you got? Is there an example of what would be is that a perfect model? No. Because if there isn't a perfect model, then we're kind of all going around in circles. But is there one which we think from other countries perhaps that might work?
Can I answer a bit of a broader question about how you put in commissioning levers to get the results? I think there's several things that need to happen. One is, as we've already said, you need to commission on outcomes, not just activity. Now, that has to be a move so you don't destabilise the system, but activities and outcomes. There's already that in the NHS, the blended payment approach. It's called the Aligned Payment and Incentive Scheme in the NHS payment scheme. It's there. Why is it not being used? We need system-wide commissioning, so people to get around the table and NHS partners, hospice sector partners deliver together, so there are not perverse incentives for any one party. There needs to be a 5-year commissioning cycle, at least. There needs to be risk-sharing agreements, because when you think about the hospice sector, it's delivering its 660,000 bed days a year. They are the most complex people. There's a lot of risk there, and particularly there's a lot of risk because the demand is rising so fast. So there needs to be risk-sharing agreements between the ICBs and the commissioned services, but there also needs to be payment limits for the over and underperformance. We also need to bring hospital specialist palliative care to this party because they're completely off the radar. Cinderella services, but they could do a lot on a very little. And we could also think about them becoming commissioner-requested services, which has a greater degree of governance, which protects continuity, and which protects the essential services. So some of the tools are already there. They need to be implemented, and they need to be implemented across all the ICBs. And the ICBs need to be very clear what needs to be commissioned. The service specifications are there. We've got them. It's just not happening. And the other thing I would add, we need to invest in specialist palliative care to save the NHS money. We've had the elephant in the room is, why does the NHS not consider death part of its business in the way that birth is part of its business? We've had a system for many years where the charities stump up the money, and while that's happening, people in the system, if I may, in the NHS system, are happy to let that happen, because why would you disturb something that's giving you plenty of service and the charitable sector's there? We seriously can't carry on like that for 2 reasons. One is the complexity of people's needs. People now have multiple conditions. It's complicated. All of the GPs and district nurses I've talked to tell me it's actually really complicated now, and the hospice sector picks up the most complex. And also the need is going up vastly, so the charities can't keep up.
Thank you very much. Matt, please.
Thank you, Chair. We've spoken a little bit about the commissioning process and some of the funding, but I wonder if you could talk a little bit, Fliss particularly, you mentioned some of the what to do. So can you tell us a little bit about recent innovations in the provision of palliative care that you think have the most potential for the future?
You want to answer that one?
Well, okay.
Yes.
We looked at, sorry, turning over somebody else's papers instead of my own. In the commission, we looked at different innovations, but I think that can almost be a distraction. As I said, we know what to do, we're just not doing it. And if you're going to innovate, you've got to innovate for your population to meet the specific needs of your population. And if you're looking after a population, for example, in Bradford, where we know that Jamila Hussain has done amazing work with a very ethnically diverse population with very different expectations from perhaps leafy parts of Surrey, Epsom type area. You've got very different populations. What will work in different areas is different. So I worry that people think, innovation is going to be the answer to this. The answer is do what we know needs to be done first of all, and quite frankly, get on with it, and give people the space, just the bit of space to be able to innovate. Because if you do, they come up with fantastic ideas. One of the things I do is I chair the Bevan Commission in Wales, and we have an exemplar programme. We do it with remarkably little money, but we encourage healthcare people who have got some idea of how they want to improve something in their service to try it out, develop it, and really experiment with it. Some of those fail, some of those are successful. But you can't just go from the successful ones and say, right, adopt and spread everywhere, because the template that you need in place isn't necessarily there. So the one thing, though, that we mustn't forget is the importance of research. And it's the specialist palliative care teams, often in conjunction with hospice services that have got specialist teams in them, who are actually undertaking the research, particularly multi-centre, and that is the thing that will move the frontiers forwards. So don't just stand still, but recognise that locally people will have ideas and they need to be supported to develop them. That should come in within that context of risk as well, because some ideas will fail, some won't, and some will be successful. But I do worry that there is an over-reliance that some brilliant new idea will come along, when we've known for decades the simple basics, and it is tragic that we still have patients where we get the referral and we're saying, if only we'd seen them weeks ago, if only we'd seen them months ago, and they haven't even had the basics of pain and symptom control sorted out, let alone the difficult conversations, let alone the psychological support to the family.
I'm going to bring in our guest, Colette, in a minute, but I just want to bring in Anna Dixon first, please.
Yeah, you mentioned Bradford, so I couldn't resist that being my local patch. Thank you, Laura. And just really to see whether this would be an example of what's on the We Know It Works and why doesn't everywhere do it. I got to visit the REACT service, which was a partnership between Bradford Royal Infirmary's A&E department and Marie Curie's Bradford Hospice, putting those specialist clinicians in the emergency room so that when people come with that emergency mission, you could turn them around quickly, get them discharged through partnership. And I know that West Yorkshire also has a provider collaborative. Do you see these as sort of part of this package of what the MSF and Future should be doing, particularly to meet the needs perhaps of more deprived and diverse communities which we serve in Bradford?
I would absolutely agree with you. So when I say hospital specialist palliative care, that's exactly the kind of thing I mean. Enough of a team to do the basic specialist palliative care that's needed, well, I shouldn't say basic, but the specialist palliative care that's needed, but also to be in the ED and work collaboratively with the hospice sector. Yeah, absolutely, but that needs to happen everywhere. And we don't even know at the moment how many people are working in the hospital specialist palliative care teams, let alone what are they doing, and are they adopting that kind of ED approach. There's a few other things, though, I think the MSF would need to think about. So we've talked about timely identification. I know Stephen Kinnock last week was saying it's palliative care registers with GPs. I would not put my money in that space because we don't know what happens to people after they go on the register. And you're much more likely to get on a palliative care register from your GP if you've got cancer. The dementia, multiple conditions, non-cancer, they don't get on those at all. So it's very inequitable. And that's why I say bringing earlier identification into hospitals has to happen. Almost everybody gets admitted, and all the groups that miss out are admitted more. So the ethnic minority communities, the people who are more financially under pressure, the socioeconomic deprivation areas, they're all in the hospitals. And so that's why we have to act in that space to complement the work of the hospice sector. Otherwise it just doesn't work, and you have to have a system-wide approach.
Thank you.
Thank you very much, Anna. Paulette, welcome to the committee.
Thank you. Before I start, I should do some interest. I was a nurse till I gave up my registry last year and worked in the palliative care field for points in my life. And also up until November, I was the APPG joint chair for hospice care. So I thought I should declare that as an interest. Could I start by saying good afternoon to all three? And I would like to direct my question to Toby. And the reason I want to direct my question to you, Toby, is through the 10-year plan, we've looked at the shift from hospital to community care. Now, we all know that palliative care is really, really, really important. The thing that bothers me most is we are moving towards strategic commissioning. This is what they're talking about. At the moment, the way that the service is being funded is very ad hoc. We've talked this afternoon about grant funding. We've talked about charitable funding. But everywhere you are within the country, it's slightly different because, as you know, I'm from Birmingham. So the money we get for charitable funding, it's nothing like you guys would see in, say, Oxford or York. So my question is around, as I've said, strategic commissioning. What are the benefits of shifting to strategic commissioning and contracting of palliative care, Toby?
Well, they're huge benefits, Paulette, thank you. And the first one is because it is a recipe for reducing, ultimately eliminating the inequality. Over-reliance on charitable fundraising to deliver an essential healthcare service is inherently inequitable. We should celebrate the generosity of our communities. But obviously, if you outsource to a local community the responsibility for paying for specialist and generalist hospice care services, it's a statement of fact that a hospice in a wealthy stockbroker community in the southeast is going to have more ability to sustain services than your community in Erdington, which has seen cuts of the services. You know that very directly. In terms of strategic commissioning, we are obviously hugely in favour of the strategic commissioning framework and specifically the ICB's move away from grants and to providing contracts. I mean, the only caveat I would say, which it just doesn't dilute that support, but the way that hospices are funded now is so unstrategic that we're not even at first base. And we're at such divergence. So it's the same way, Fliss, when you talk about moving away from activity towards outcomes, hospice CEOs would give their eyes teeth to be funded on activity. So the rest of the NHS is already talking about moving to outcomes, whereas hospices just get a grant, a contribution, without accountability on either side. And so, we do believe that the most broken part of the system is the local commissioning of hospice care services. And we think that, after several decades, it clearly can't be left to every ICB individually to fix a system that is hugely variable and inequitable. And that's where there has to be, I think, some kind of central mandate or framework that has to be followed. And
so can I just do a follow-on point, because I know we have to move on. For me, the big issue, I have this thing about data. We are struggling to get the data from hospices. So the question I'd like to ask, and I don't mind who answers this question, what would you like to see the government do to increase their data collection to enable us to get proper strategic commissioning?
Well, if you go to the NAO report, section 20, DHSE and NHS England do not know what proportion of the amount of palliative and end-of-life care provided in England. There is not enough data. There's an absolute lack of good data locally and nationally, and I think that should be a concern. I note that this committee, that towards the end of the oral evidence you held on the DHSC annual report and accounts on the 13th of March, that the chair and yourself, Anna, you asked Professor Whitty about that you were concerned that there was hardly anything on palliative or end of life spend, performance, outcomes, volume, the hospital services, Fliss, that you've been talking about.
I wonder if Fliss would like to come in, because I have to move on to give back to the chair. Is there anything, say you had 3 government ministers sat here, what is it, what message would you like to tell them so that we can see strategic commissioning really start to...
Well, I agree with Toby that we need to know the activity. We don't know the activity well enough. So some hospices have done a lot of work to build a dashboard and get their information to the ICBs and into the linked health and social care data sets that are beginning to emerge around the country. So there's some innovation in that space. The trouble is it's a very fragmented sector. As we know from the NAO report, there's a lot of variability in the provision, and there's also a lot of variability in the data ability, if you like, both capturing it and reporting on it and feeding it into the centre. We've lost a lot of what we did have in the past, and we need to rebuild that. So we used to have, annual reports, didn't we, on all the activity. It's much less good, although there's been really great efforts by Hospice UK to be leaders in the sector and move them forward on that.
Thank you.
So it's going in the right direction.
On for the last word to Baroness Finlay, because I have got to hand back. So Baroness.
I think what I'd say quite simply is that there needs to be a clear funding formula. You need to know the workforce that is actually working at specialist level, and you need to know where it's happening 24/7 availability, with telephone support to all the families and the patients who you've got listed, working with your local hospice so that you're including them within your funding formula framework. And you have to know the number of your workforce, because I'm not sure that people even know for one ICB to another how many staff they have working at specialist level and how many they have working in different ways.
Good place to stop. I'll hand back to the chair.
Thank you very much. Very succinct, Paula. Thank you. Clive Betts.
Yes, just focus on the overview that you've taken, already answered some questions about. We talk sometimes as though hospices and the NHS are 2 completely different things, different worlds. And actually, we're dealing with the same people needing treatment at the end of the day in different forms. So, how can we get a proper overview and integrate the services? I mean, you referred to the fact that A&E departments ought to be referring people on. GPs did. The reach-out care from hospices goes into the same communities that district nurses are operating in. So how can we get a better joined-up, integrated approach?
Can I say very briefly, and I don't want to take much time, what we did in Wales from 2008. We came up with a funding formula for a population, for a number of hospital beds, for a number of tertiary care centres, of the number of specialist people that we needed, the number of hospice beds that we needed, irrespective of who was funding those, the number of home care team staff that we would need for a population. Now, it was pretty rough and ready, but it was better than nothing. and it gave us a starting point, because I would completely agree with you. Up until then, it seemed as if we were operating in different worlds, and we had to be able to get staff to move around between the different bits of the sector to meet the needs of the patients, because the patients move around between the different bits of the sector, and we had to have integrated clinical notes and so on.
May I add something to that? I think on the ground, a lot of teams work very well together. Yeah. What's not happening is commissioning at a system, strategic level, where those elements might be, in one area, might be provided by different folk than another area, but it's the population needs that we need to drive it from.
Just one additional point, and we talk about data and looking at the best way to do things. As a committee, we look at value for money. Should there be value for money assessments on how services are delivered in what way between different organisations in order to see how the money is being spent and how it can be better spent?
If you collect outcomes against knowing what you're commissioning, you will get that information. I know that sounds a bit simplistic, but unless you actually measure outcomes, you will not know whether you're getting value for money or not.
And you have to be very careful in this space, because the cheapest person is the person who died 6 months ago. What I mean is, if you want to give them good care and ensure they have the best possible end-of-life experience, we as a society have to commit to using some of our health service money to support that. And so therefore the outcomes you're looking for are the quality of care and the quality of life for those people. And we can improve it, we can deliver it, and we do deliver it, it's just not enough of it. And we also know if they desist from some of the high-tech hospital-based interventions, we'd have a lot more money to make sure they had a better end, better symptom control, better support for the family.
Yes, Toby.
Just to close on that question, I agree with what the Minister said before the Health and Social Care Committee last week, which is that hospices aren't looking to be, if you like, absorbed into or fully taken over by the NHS. We value our independence. It allows us to innovate. It allows us to, Cicely Saunders says we stepped out of the NHS in order for new ideas to flow back in. But this question of integration, there's so many hospices that are sharing consultants with the acute hospitals, housing district nursing teams with community hospice at home teams. There are some hospices that are totally integrated into the hospital and GP practice information system. So a lot of good practice is going on, and we shouldn't allow this to be a sort of either or, suggesting that in order to be fairly funded that hospices need to become part of the NHS. They don't. They just need to be fairly funded by the NHS. It's a very different thing.
Yep.
Yes. Thank you very much, Clive. I've got two very quick questions because we're sort of almost out of time. On the back of Clive's questions, really. I'm sorry to boil this down to numbers because we deal with numbers in this committee, but we understand that behind all the numbers is a person who needs treatment, and particularly their family needs supporting. So if the evidence from Rotherham Hospice is correct, that a night in a hospice costs £765 compared to £1,000 or £1,200 in the NHS, if you agree with those figures, Professor Fliss, your 30 million patients at any one time in the NHS, a third of which are in the last year of life, so 10 million patients in the last year.
So not 30 million patients, 30 million bed days in hospitals.
30 million bed days,
yeah.
okay.
Yeah.
And a third of those are in the last year of life, I'm sure that a significant proportion of those would be more correctly referred to hospices. Given the figures that I've just given, it does seem to indicate that there is a substantial imperative to getting the data and, much more importantly, the diagnosis. You were referring to earlier diagnosis, correct? So that
earlier
we could get
identification, not earlier diagnosis.
Identification, yes. Get it done earlier and quicker so that we could get people into the most appropriate setting towards the end of their life. There's a big financial incentive to do that.
Yes, if you give people specialist palliative care, be it in hospital or be it in the hospice sector, in hospices and in their homes, they will have fewer hospital bed days and better quality of life. And it is cheaper. So why are we not doing it?
Thank you. That's what I expected you to say. Now, I don't know whether you heard Dr. Vicky Price, President of the Society for Acute Medicine, on the Today programme this morning. Basically, to summarise what she says, looking at that third that I've just referred to, we admit them and then over-treat them. She said one patient she saw recently was in his late 80s and had 14 appointments booked for the next 2 months for health problems, including cardiac and renal issues and liver and eye problems. I talked to him. The only thing he really wanted to keep an eye on was his eye treatment. Are we in the position of over-treating people towards the end of their life?
Yes, we are. If you look at the Right Care series, which was published by The Lancet a few years back, it's very clear that we over-treat people. So what that means is that we have a whole barrage mainly in the acute sector, of interventions that can now be done. And they are highly technical and they're brilliant. And they sometimes save lives, or extend lives is the real term. The trouble is we keep doing those things which have been developed usually in one condition evidence, not in multiple condition evidence with older people. And we keep offering people those treatments and they keep taking them because the conversation goes like this. This is the treatment I can offer you. It is not about, actually, you're not doing so well, you might deteriorate, things might not go so well. Shall we think about what benefit you might get from my fancy treatment, as well as what benefit you might not get? So that complex, what I call a serious illness conversation, does not really happen often enough. We've got the evidence for that. 40% of those families just didn't think that had ever been discussed with the person concerned in the last 3 months of life. So I think we do over-treat people hugely, and we need to be much more judicious, A, about understanding what a treatment can or can't offer for older people with multiple conditions, but B, being upfront and being trained to have what are very difficult and sensitive conversations. I'm not advocating that we withhold treatment or we ration treatment. When people understand what a treatment can or what an intervention can or can't offer them, most of them, actually, the older people, do not want. They tell you, I don't want to be messed around with. I don't want to be sent for another MRI scan or another CT scan or another investigation. And we hear again and again from families, I wish I had known. I wish I had known the trauma and distress that would have been associated with being in a hospital, having lots of tests, having lots of treatments. It is not easy. And if they had known that somebody was deteriorating, they would have said, well, no, can we just take her home?
Well, on that sad note, but important note, can I thank all of you? This has been a fascinating session, a session where it looks as though we should be and can make significant changes, hopefully for the better of the people themselves towards the end of their lives. So thank you, all three of you. You're all very busy, but very knowledgeable people. We're very grateful to you this afternoon for your evidence. Did you, Professor Fliss, wish to say something?
I was just going to say, I do have a briefing paper with the sources of evidence that I've spoken about. I
was going to ask for that. I would be very, very pleased to see that. Thank you. So the clock stands at 16:36. If we could be back here by 16:45, say quarter to latest. Okay. Order. Thank you. Order. Welcome back to the Public Accounts Committee on Monday the 12th of January 2026. We now move into our main session. We've just heard from an excellent panel of witnesses about the challenges currently facing the adult hospice sector. The NAO's recent report on this subject found that the NHS commissioning of palliative and end-of-life care has not yet fully moved on from its historic use of grants to commissioning through contracts. This means that the picture is not always as clear as to what services are being commissioned or whether the local demand is being met. The report also found that the NHS commissioners are unable to fully understand how the funding they provide to hospices is being used to support patients and their families. So today we'll be looking at, therefore, to challenge the Department and NHS England on the sufficient provision of palliative and end-of-life care and the role of independent adult hospices. We will also be examining how NHS England commissions and funds palliative and end-of-life care from an independent adult hospices in England, and exploring how the department plans to support the long-term financial stability of England's independent adult hospice sector. So once again, I'd like to reiterate that we're not going to stray into a debate on the assisted dying, as this is not the purpose of this inquiry. So today we have with us, obviously, the Permanent Secretary, who we're very pleased to welcome. I think, Permanent Secretary, if you'd be very kind and introduce yourself, and then each of your team can introduce themselves, then I won't get it wrong.
Thank you very much. Good afternoon. I'm Sam Jones, Permanent Secretary at the Department of Health and Social Care.
Jim Mackey, Chief Exec, NHS England.
Hi, I'm Duncan. I'm the Chief Nursing Officer for England, and I should also just note that I'm a trustee of a hospice.
Amanda Doyle, I'm the National Director for Primary Care and Community Services at NHS England.
I'm Scully, I'm the Director for Primary Community Health Care at the Department of Health and Social Care.
So I think a particular warm welcome to you, Dr. Edward and Dr. Amanda and Duncan. You've all first time in this committee, I think, so a special welcome to all three of you, and thank you all for coming. So to start us off with all of that, let us go, please, to Paulette.
Good afternoon, one and all. My question is quite a simple one, and Samantha, I'm going to direct, if you don't mind me calling you Samantha, I'm going to direct my question at you. My question is simply, let me start by saying, with the 10-year plan, with that left shift that we've talked about, we know that things are moving more and more into the community. And what that means is that when it comes to palliative care, we will be getting larger numbers of people within the community setting. Can you explain to me how will the NHS meet the expected increase in the demand for palliative care in the coming years?
Thank you. And if the committee are comfortable, I'll start and then hand over to Jim the details. So I think for all of the panel members, and certainly for myself personally, hospices are a core part of the service that is provided. It is not a nice to have. For many of us, and we will all have personal experiences around end of life care, whether it's for members of our family or indeed people that we have been with over that period of time, and it is extraordinary when you are part of that experience of somebody at end of life, and particularly within a hospice. As the Secretary of State has previously said, we do know there is a gap between where things are now, and indeed we will. None of us believe that end of life care and the services it provides is where we would like it to be. There is a gap between where we want it to be across hospices now and in the future. So reform is not an option, and from our perspective, collective perspective, and that of the Secretary of State, we are committed to making sure that reform happens in practice. I'm not avoiding your question, so just...
Sorry, I was going to butt in, but I'll give you a few more seconds.
I just wanted to start with a very clear personal, this is not a nice to have for any of us, for the Department, for NHS England. And in terms of your question around the future, in terms of NHS England and the demand, Jim?
Yeah, so in all of the discussion about this, I think there's a lot of common ground. None of us are happy with where we are now. It's very inconsistent around the country. We're not as clear nationally on the standards, how we're paying for things, how things are being commissioned. So as you said, Paulette, the 10-year plan sets off some direction or vision around neighbourhoods. There's similar stuff, all the stuff that we're doing around modern service frameworks, more of a focus on quality and outcomes, payment mechanisms. All of these things should over time allow ICBs to commission to a consistent set of national standards for end-of-life care. That will, again, we'll all probably agree we've got people in the wrong places now, sometimes people in more expensive settings than they need to be, and over time that'll become more ordered. There'll have to be some growth over time as well.
We know each other well, so I'm going to just stop you right there. How will we do that?
Yeah, so the intention is the modern service framework will set out this is what good should look like. There'll be support for commissioners in all of that. We'll expect commissioners to start getting clearer about palliative care, end-of-life care in their patch as a whole system, how everything fits together. We will produce over time clearer payment mechanisms and contractual guides, etc. And they will be the things that start putting this thing together. Ensuring the consistency of standards, focus on outcomes, focus on value for money. One of the big things in this is the emphasis that's required on engagement with families, engagement with the individual as well, and making decisions together. All of these things have to happen together for that to work properly. And it'll take time to get there from where we are now.
So my last question, then I'll hand it back to the chair. My biggest thing is about data.
Yeah.
How do you find out?
Yeah.
What is it? Where's that deficit? So we can then do what needs to be done.
Yeah.
What, as NHS England, the Department of Health, what have you all got planned for the future to ensure that hospice care is not seen as a second cousin once removed, and is seen as the expert service that it is, that's delivering a first-class service, but you're able to measure it?
Yeah, absolutely. So you've heard me bang on before about the evil block contracts and stuff, where we've got into a position where we just have very large sums of money with very little specificity about what that's commissioning or buying. That will be built out. It's all being unbundled now. Over time, we'll get to these sorts of services, so there's then more clarity about what is actually being commissioned. We'll have to get better, stronger data standards, consistency to a set of national standards. And this will take a few years. We'll then be clearer what the differences are, what the variation is. Commissioners will have more data to drive commissioning decisions, and we'll have better data to hold the system to account for. That's not where we are now. It's very inconsistent. The data is very poor. There's huge variation behind all of that, so it's going to take quite a bit of unravelling.
So I'm going to hand back now. I don't want you to answer, but I'm going to leave you with this question. Toby from the last panel, he actually said by April, many organisations will go under. They haven't got years. So as people are asking their questions, you need to answer that point. Thank you, and I'll hand back to the chair.
I should have welcomed you for this session, Paulette. Paulette, of course, is from the Health and Select Committee guesting on this, and you're very welcome here, Paulette. I just want to follow Paulette's question. Given that we're going to abolish NHS England, and therefore the ICBs are in considerable flux at the moment, they've been a the hospice care sector has been a neglected sector. I think we would all admit that. If we're putting ICBs under additional flux by all this change, you can produce all the 10-year plans you like, but how do we know that anything is really going to change in this sector?
Whether NHS England is abolished or not, the functions remain and the functions are required. And so as we go through over the next year, we've talked about before, and design the operating model for the future of the department, these functions are very clearly required for ICBs. I think the committee will, of course, be aware the medium-term planning guidance that was published requires ICBs and providers to actually understand their need, understand their population, and understand the future projection from a demand perspective so that we can ensure that we understand, pick up Jim's point about the data. So the modern service framework that Jim described will set out with people, and it's really important that we do this with people, with families, let alone hospice sector themselves, will actually set out what is required, whether it's now or if it's over the next year, subject to the abolition, subject to the will of Parliament, and future in the department as well.
Okay, well, we will test that in the future, but thank you for that answer for now. Sarah Hall, please.
Thank you, Chair. Good afternoon. I want to look at the number of people who are dying in hospitals at the moment. So we know that demand for palliative and end-of-life care in community settings is increasing. So what's being done to reduce the number of people dying in hospitals and to support the greater number of people who wish to die at home? And I guess, Samantha, do you want to start? Or
I think if I may add to Amanda, if that's okay.
Oh, yeah.
So one of the things we are doing, we've as Sam and Jim mentioned, we've put an ask on ICBs to actually treat the cohort of people who need palliative and end-of-life care as a priority cohort for starting to develop the shift out of hospital from April this year. And the big part of that is understanding their data and what the needs of their population and the prevalence is. We do have a dashboard, a palliative and end-of-life care dashboard, which covers all the ICBs, and ICBs can drill into looking in quite some detail about their population, the numbers of people, the numbers who are in hospital at the end of life, people who die at home in hospices. We know that there are a significant number of people who are in hospital and for whom we're not offering anything from which they can benefit additionally and who would rather be at home. And so it's around ensuring that we develop the MSF in a way that it's very clear what the evidence base is and what we expect ICBs to commission, that we support ICBs to become better strategic commissioners so that they, despite reducing in size, they increase their capacity to understand the data and apply it to improving the outcomes for their population. And we are starting a strategic commissioning development programme and improvement programme for ICBs to help that happen, and we're launching that in April. And then it's really important that we tie this to some of the other things we're doing, like the long-term workforce plan that will be published this year, because it's really clear that the workforce focus is going to be important if we're going to look after more people in their own home. So not only more people who can deliver specialist palliative care, but there's an equally large group of people who may not need specialist palliative care, but they need general end of life and palliative care in their own home, and that involves general practice, particularly community nursing. We do need to focus on community nursing input, and then we need to work with other sectors like pharmacy. We've got to have the medication available so that people aren't left in pain or with symptoms and end up defaulting to an ambulance. And so there's quite a significant piece of work for ICBs to look across that data and understand those needs and deliver that shift in services.
Yeah, can I just add to that, because I think it's really important that conversations happen earlier when we identify people in the last year of life, and being able to have those conversations, making sure that there are advanced care plans in place. And we've seen the number of advanced care plans go up, but we've got much more to do in that space, because there is something about having honest and open conversations with patients and family members about the choices that they have towards the end of life, and whether that's a choice of wanting to die at home, in a hospice, in a hospital, and making sure therefore that plan is set so that all the clinicians that are working and wrapping their care around those patients is
are you confident, so in terms of the challenges that this is going to bring, that ICBs have that knowledge? Because it's not just a question of funding, is it? It's things like the way that services are currently organised, and absolutely, as you said, that kind of coordination that maybe isn't happening, that communication so that families know what's available. One of the things that I know has been highlighted in the MSS is that the lack of 24/7 community care. So obviously things like that need to be put into place so families have that confidence. So Do you think that the ICBs, in terms of that kind of wider strategic side, they have that knowledge about what the challenges are?
We, a group of ICBs, Hospice UK and independent hospices, co-produced and wrote some ICB commissioning guidance last year to support ICBs with a greater range of information about what the evidence tells us and the steps they should be taking. That's been circulated to all ICBs. We've now got the strategic commissioning framework. As I say, we're about to launch the development programme. It's really important that we don't leave ICBs to guess at some of this stuff. We know we have evidence about the interventions that make a difference, 24/7 access to advice around specialist palliative care and support and coordination of services is
also
key.
to have that one set of kind of guidance that everybody follows. So
That's
obviously
right.
there's a lot of variation at the moment, just having that one set of guidance that they all adhere to.
I think that's something that, sorry to interrupt, that's something that Minister Kinnock said at the Health Select Committee last week. As Amanda says, there's different service specifications, there is commissioning guidance, we've got the broader strategic framework for commissioning. As Minister Kinnock said to the panel, the modern service framework is a way to bring it all together into one place, to set that data, to set the kind of in one place what the framework will be, what the vision will be, what the data will be, and as Professor Murtagh was saying earlier, how will it be delivered and how will it be measured and ensured it will be delivered. So that I think was Minister Kinnock's ambition with the MSF.
Thank you. Can I, on workforce as well, so I've read quite a lot around workforce shortages. So, I mean, is there a plan to try and tackle some of this as well to make sure that you've got the right people in place doing the jobs?
Well, I mean, look, I think we've got clearly the 10-year workforce plan that is being developed, obviously looking at workforce within the NHS, and that obviously needs to factor in, those services that support and are commissioned by the NHS. And, there's a number of things that we've got to do going back to kind of how do we shift from hospital to community. So for my profession, for example, we are still trained in a very hospital-centric way. If I think back to my training 30 years ago, I did probably 12 weeks of community in a community setting out of 3 years of training. That's very similar still. So we've got a big job of work to do around how do we change the way in which we're training professionals to work in community settings, because it's not just about those that work in hospices, but also those community services. And one of the commitments in the 10-year plan was to develop a strategy for nursing midwifery, which we will be coming out with in the spring, and we'll have elements of that in there.
One of the key pieces of evidence about good quality palliative and end-of-life care and therefore good outcomes is continuity of care makes a difference. So it's absolutely vital that we recognise that to have good continuity of care, you need the capacity in the workforce to deliver that. And I was a GP for 25 years, and so you see that really, really clearly. You're much better able to support families and patients at home if you know them and if you see them.
You can have those honest conversations.
Absolutely.
Did you want to say anything?
I was going to say, one of the things that came up about the workforce in the previous session was that we don't know the numbers. That's not quite right. We do know the numbers. So we know there's 910 FTE palliative care doctors, 420 of those are consultants. But it'll obviously be for the long-term workforce plan, which I mean, a lot of this will be built into neighbourhood health, because there's the 3-year planning guidance. Areas need to focus on, well, there are 2 priority cohorts, those who are frail and those at end-of-life care. So I think there's already kind of quite a lot of push has gone to the system to focus the system on palliative and end-of-life needs.
I wanted to ask a question about the inequality of access as well to palliative and end-of-life care. So we know that there are significant inequalities in terms of access based on geography, the conditions, or indeed just affluence of an area, how deprived an area can be as well, in terms of whether there's a hospice, a charitable hospice that's able to raise the funds that are needed to exist. So it's also a reflection of the lack of planning, the way the sector is developed. So, I mean, how do we address this? How do we make sure there's that equitable access across the country going forwards?
I'll just make 3 quick points and then hand over to colleagues. So I think you're right, there is a correlation. If you look at how, if you look at the place of death for hospices against the kind of the indices of multiple deprivation, you see the numbers jump up for more wealthy areas, I think by 2% every kind of decile it goes up. So there is a huge kind of correlation with it. As you kind of get at, it was an organic system. It developed up organically without a kind of a national overview of how it would. I know Hospice, I don't know if Toby's still here or he's gone, but I know that Hospice UK are doing a lot on how do they diversify and look across different areas and try to kind of boost up provision in other areas. But the requirement on the NHS is to provide palliative and end-of-life care to everyone across the whole country. So regardless of whether you've got hospice in that area or not, the NHS has to kind of meet that statutory duty. Can I just one thing that I found that really helpful that a hospice chief exec said to me in terms of understanding kind of some of the funding issues. They said there are basically 3 levels of palliative and end-of-life care treatment. First of all, you kind of got your core and general support, which is the vast bulk, specialist palliative care, and then the top level is the enhanced level, which is what hospices add. That is kind of not the NHS offer. And I think when I've spoken to hospice chief execs, they've said they fully accept that is what they should be funding themselves, and that is what the charitable kind of donation should be funding. What they're looking for is the kind of the fair remuneration for the core and then the kind of the specialist care. But I think it's just, I find it as helpful kind of framework to understand that that's kind of how they see their funding.
I think one of the, I mean, going back again to the data, which I know we kind of expanded on later, the need to improve the data collection, the understanding, we've got a limited idea in terms of the activity, the quality and the spending on community services more broadly. So we've got this, you're talking about that statutory service, that statutory provision, but how do we know that, you know, people are getting what they need? How do we know that people are, you know, have access to the choice to whether they want to choose to die at home or to die in a hospice, or, you know, if there aren't the provisions there and we don't have the data to know what's going on.
There's two key bits of data Amanda might want to come in. First of all, there's the dashboard Amanda mentioned, which is like a really substantive and comprehensive piece of data that kind of shows, it's a retrospective of previous years that shows you how many people died, what area they died in, what they died of, inequality things around ethnicity and indices of multiple deprivation. So we've got a really, really good kind of understanding, and that is a tool that ICBs can use to plan. The other thing we do a national audit of end-of-life care at the end of every year, and NHS England fund that. So we've got kind of, I mean, the statistics are slightly different to what Professor Murtagh was saying earlier, but we know, for example, 97% of hospital providers have access to specialist palliative care, but only 61% have face-to-face cover 8 hours a day, 7 days a week. 73% of bereaved people rated overall care and support good. So we have got data. We need more, but we do have quite a few sources already.
You would say that you're aware of where the gaps are in provision at the moment?
I don't think we would yet say. None of us would say that our data is strong enough or robust enough to be able to do exactly as you say. I know Amanda wanted to...
So, independent hospices who are contracted and funded by ICBs to provide services, as opposed to given grants with which they provide services, are obliged to report data on patient-level activity. And just the fact of that reporting means we can add that activity to our community services data set. Even 2 or 3 years ago, we had very poor data in general around community services, which made it very difficult for us when we were trying to understand the commissioning needs and spend. That is very significantly improved. We have a programme called the Faster Data Flows programme, which is about onboarding community providers into automated daily patient-level data collection. We do it for acute trusts. We're onboarding community providers, and we've started to onboard independent hospices, and that will be a game changer, because the more hospices we get on board with the data flows, the more we can have an understanding. It's absolutely crucial, though, that we use that data to move to properly commissioned contracts for services on which we can then assure ourselves and oversee and evaluate, rather than the application of grants. There was an attempt in about the 2010s, early 2010s, to move to tariffs and contracts for activity. But at the time, we didn't have the data we have now, but also the standard NHS contract at the time, largely using PBR, wasn't really fit for purpose. It was more designed to measure episodes, and end-of-life and palliative care is obviously not episodic in that way. So the blockers at the time that made the introduction unsuccessful, we think have largely gone away, and the quicker we get hospices as well as other community providers of palliative care onboarded to automated data collection, the easier it will be for us to implement.
And would you agree, I mean, at the moment there seems to be a lack of oversight. So do you think it's important to have that national accountability that doesn't really exist at the moment, so that, you know, to ensure that equitable access?
It's really important that each ICB understands the patient level need as well as the activity and spend within their ICB area. It's very helpful for us to have that national level oversight, particularly when we're looking at whether we're delivering consistent standards of care across all the country for people. And it's important that it's consistent palliative and end-of-life care. We recognise, because of the way the hospice movement developed since the 60s, that we don't have equitable access to an independent hospice for every population.
We must be careful about not cutting across other people's questions. Chris Kane, please.
No, thank you, Chair, but I was just going to make a very general observation, which I think is going to get picked up shortly, which is that what I'm hearing from this panel on data collection, and what I heard from the previous panel, it's almost like we're talking about two different subjects. It's an observation, and I will leave it to my colleagues to pick up on that later.
Lovely. So, Catherine, it sounds like, in theory, the evidence that we've been hearing and the answers you've just been giving, it feels like we want to go in the same direction. I think the challenge is the reality that we're starting from and where we want to get to. So to understand how we get there, because the evidence has come across quite clearly to us so far that there is some measuring of activity, but there is insufficient measuring of outcomes. And whilst we absolutely need to improve the collection of data, I think we need to always be careful that we don't just collect numbers, but the experience of people and their families as well. Dr. Doyle, you just touched on some of the challenges around grant funding and the inability to actually measure the outcomes from that funding, and that there were some attempts back in 2010, and in fact a previous PAC report from this committee recommended to move away from grant funding, but here we are in 2026 and this is still a challenge. So what is being done to move away from grant funding, which seems to be agreed as the direction of travel that needs to be pursued? Could be to you or...
Yeah, Catherine, so as a general principle, we're moving away from things being in block contracts with lack of any detail in terms of what that's buying effectively. So that's happening across the NHS generally, and specifically we've set out that we would expect a movement away from block funding, and over time more clarity on what is being purchased effectively, commissioned locally. So we've set off a process that ideally would, if we could get it done tomorrow, we would. But it's a long, complicated process of unravelling how all the money works and how things are connected to each other, and you think it's related to that, but it actually is related to that.
Would you forgive me if I say that, this conversation's been happening now for 15 years, and that feels quite vague, not very specific. Yeah. So what reassurance can you give that this is something that is not just a ambition, but actually is a deliverable achievement that can be made?
All of the changes that we're making around the financial regime and the return to more rebuilding commissioning under the operating model changes, the introduction of modern service frameworks where it's very clear what good looks like and people should be commissioning from an ICB perspective. And we've set a process off that's now live. Some changes in the year that we're still in now, some coming again in future years around new tariffs, new payment mechanisms, incentives to incentivise the left shift so that money can move with the patients. So this, I think you can get more confident about this working for end-of-life care because it's a part of a general movement of direction for the NHS as a whole to move away from centralisation, big blocks, don't worry about what it's buying, just work it out locally, to rebuilding again the more specific nature and more active nature of commissioning.
Would you be able to give an example of what some of those incentives might look like?
Yeah, so in some of the discussions you've had and we've had with the sector, there's a clear appetite for people to be paid and rewarded more in line with clear standards, better outcomes. It's not as episodic, as Amanda said, as it is an elective care, so we're going to have to find new payment mechanisms to support that, and that's absolutely what we want to be getting into. And on Ed's point, there's a sort of specialist palliative care bundle of things that we can start over time with colleagues in the sector building prices for. Again, there's a demarcation for the enhancements that are funded through the charitable kind of context. So we'll not be looking at those sorts of things and trying to price and incentivise them. But and I think on all of this, we agree with the recommendations. It's the strong support for all of that. It's just not where we are, and for whatever reason, it's not where we've been in recent years. It's become very vague. There is an awful lot of rebuilding required to allow us to get where we need to get to.
Would you give us a sense of, I know it's a 10-year plan that the NHS generally is working to, but we're seeing the challenge around the cost base for all businesses, and hospices, operate on that basis, rising, demand rising, but these challenges around funding squeezing hospices. So what kind of time frame are you working towards to get these incentives in place to what I think you're describing as a more tariff-based system that will measure the outcomes rather than just activity?
Yeah. Did you want to comment?
So, the work is part of the modern service framework. We have done some internal work already on what some of those pricing and what some of the unit costs could be. We haven't tested them with the system yet, so we can't. But we would envisage the contracting and the commissioning as being part of the modern service framework, and that gets published. That gets published in September. Right. Well, sorry, we've said autumn, but we're aiming for September, but autumn. Then hopefully able to kick in for the following financial year. But that's what we're kind of aiming for. But we have internally, we've got some. Through the national cost collection, you collect all the kind of the data on the previous year's activity, and we've got some kind of unit prices for some things. So, for example, specialist palliative care visits out in the community, unit prices give or take £150. So we've got some already, and they can be kind of. So ICBs have got something to draw on, and some ICBs are, as you've kind of got at, it's patchy. Some ICBs are commissioning on that kind of basis. I think there's 9 out of the 42 ICBs. West Yorkshire is a good example. West Yorkshire's ahead of the game. West Yorkshire is a really, really good system where, you talk to the chief execs up there, and quite a few of them are doing kind of some of the activity-based payments already. But it's how do you level it up?
Reluctant to say we recognise the situation. It'll all be sorted through the MSF. The process that is what we're working to, and particularly making sure that we do the right engagement over the next couple of months to get it right. Some of this is about this. It's also something about how the new department wants to work, which is rather than us sitting centrally saying this is how it needs to be, it is done with people as experts in the sector, and as Minister Kinnock set out. But so that is how we are trying to address bringing together all the disparate things that you've heard about and through the modern service framework, but really importantly that it's done and engaged with people who are experts, including all the examples of good practice that we know up and down the country.
Thank you. If I could pick up, Chair, to follow on from my colleague. So we focused a lot there already on sort of data for commissioning, and I thank you, Jim, for your honesty as well, saying, is poor and inconsistent, Sam, it's not strong or robust. It is a shame that we're in a position where we've had sort of statutory commissioning since 2022, and obviously ambitions long before that to have moved in this direction. But, obviously there are various sources of data. It seems it's about bringing the right data together in the right places. Sorry, I should say before I carry on to declare a conflict of interest that I worked at the Department of Health between 2013 and 2015, and so I know Ed and some of the other colleagues from that time. I just want to get to this value for money question, though, which obviously is what ultimately concerns us. When we've previously had colleagues here before us looking at the Department of Health accounts, it's very clear, and it's again here in the NEA report, I actually don't know what we are spending on palliative and end-of-life care, and certainly not very specifically on what we're getting, what we're spending on hospices and what we're getting back. If you add in continuing healthcare, it seems that's another black hole. We don't know how much continuing healthcare spend is going on palliative and end-of-life care. So moving beyond just commissioning, how can we be confident that we're getting value for money in terms of what we're spending on palliative end of care and the outcomes that we're getting? I don't know who wants to start on that one.
On the spend, one of the you heard evidence from Professor Murtagh earlier, and the department set up the policy research unit that she mentioned in 2024, partly because we don't have enough information. So the report that Professor Murtagh published last year that she mentioned earlier that set out, it's on the average cost of someone dying is £24,000 per year. In 2024 money, that means £12.8 billion was spent on palliative and end-of-life care. That includes the statutory spend on hospices, but not the charitable spend. So if you include that, that takes you to about 13.4 billion, which is give or take you in the region of 7 or 8% of the overall NHS budget. I think the difficulty with being able to account it in a kind of like a real-time way, it's quite tricky. First of all, you've got the different funding mechanisms that work across the different systems. So in general practice, you've got a capitated system. You've probably got the best data in the acute system. But not all episodes will be coded as palliative and end-of-life care. So I think it's, I mean, I don't know how to do it, but it's incredibly difficult to be able to do it real-time, I think.
I guess it comes to the point of allocative efficiency then. We're hearing lots of evidence from our pre-panel that basically says, spend less on community hospice services, you'll end up with spending more on acute hospital beds. Amanda's talked about wanting to shift more into the community. That would suggest spending more on hospice community activity if you're going to shift out of hospital. So I realise that the accounting may be difficult, but is it not absolutely necessary for you to make decisions about where to put the money to get best return in terms of palliative and end-of-life?
It is, absolutely. It is, absolutely. So as Ed's pointed out, you can look at this in different ways and come up with estimated costs for what's currently being spent. I'm just thinking in my old previous chief exec lives, because of the differences around the North East, as an example, and the way palliative care is provided, I wouldn't be confident everybody's counting said things the same thing. Sometimes it's provided in the NHS, sometimes in the hospice sector, it's sometimes hospital, sometimes community. It is a real patchwork. So I think what we're trying to describe is we're setting off on a process. The MSF, let's not overcommit it, but it will set out what good looks like. We're being clear with commissioners what they need to do. We want the sector, the NHS to work with the sector effectively. We'll be more transparent with the data when we've started getting data on outcomes and on value for money, and that'll help with accountability and clarity on how it all works together and what good looks like and who's closest to that. The thing we'll keep going back to is we're not in that place today. We couldn't do that today without it being hugely inaccurate. And it's going to have to be built up over a period of time. But it is also part of that broader rebuild of how accountability works, how commissioning works, how value for money works, transparency. It's all part of the same thing.
And of course, as you'd expect me to say, it's all part of the broader shift through the 10-year health plan, neighbourhood health, being very clear about where and how people should be receiving their treatment and being part of the decisions around their treatment. I think what we're trying, we're acknowledging is that we know the data in itself won't fix the issue, but we also know that we need the data to be able to do the stuff that is absolutely required to do and break down the data both in terms of because it cuts across multiple pathways as we've described, so making sure that we understand what the data is to be able to support the ICBs to make their commissioning decisions, focusing on avoidable admissions, and really importantly, I think as Amanda said, making sure people have the choice about they are involved and they have the choice about where they want to be treated and indeed where they would like to die in the future.
You brought up West Yorkshire. I'm enjoying this inquiry today because I've had two local examples praised, Bradford by the pre-panel and now West Yorkshire. We are hearing, obviously, the stress that hospices around the country are in, that it's urgent and immediate. And there's a real risk that if they further reduce their services from April, that is going to lead to additional demand and cost on other parts of the NHS. Do you think that whilst we're waiting for all this perfect information and strategic commissioning and leadership support and guidance to come through, that provide a collaborative model where you just say, get together in an area like West Yorkshire have and find your solutions locally is what we have to do? Because I worry that otherwise we're going to see sort of us going backwards rather than forwards, and it will make it even more difficult. So you held up the example of West Yorkshire, the provider collaborative. Do you believe that model is something that other parts of the country could look to more immediately work in partnership with their hospice sector to basically sort out where the money is best spent.
Sorry, go on. So absolutely, there are huge benefits, not least because small individual independent hospices can't benefit from the economies of scale that they can benefit from increasingly if they work as a collaborative. But also for ICBs looking at their patient level need across a patch, it's much, much easier to effectively commission from a collaborative of providers. And what we do know, and we don't need to wait for the absolutely accurate data to find out, is that we are treating many, many more people in the most expensive part of the sector than are able to benefit from it and are actually not getting a service that a much more cost-effective part of the sector could give them. And so it's really important that we don't sit back and wait till we've completed everything before we get on with, as you've described in West Yorkshire and other places, with actually letting local people move forward.
Thank you.
So before I bring in Paulette, Permanent Secretary, I am struggling with this because what I'm hearing from you is that you have good data from these dashboards, but on the other hand, the NAA report time after time says because you've been giving out grants for years and years and years, you can't have the data to know precisely where you ought to put your money. In other words, a precise contract to provide a precise service. Dr. Edward Scully said that should be the core service, not an add-on service. You can't know. Yet you're about to produce an MSF, which is going to transform the whole system, according to Sir Jim. But how can you transform the system if you don't have the data?
If I may, Chair, I don't think we have said we have perfect data. I think we're at pains to acknowledge to the committee that we don't have perfect data. We have dashboards across the ICBs, which is giving us some data. It isn't giving us and it isn't consistent, and it isn't giving us the level of detail that we require to be able to do the things that you're describing. So I wouldn't want the committee to feel that we are sitting here saying we have got good data. We have some, and the ICBs have some data. I think if I may, I think what Jim was describing, and I think as Minister Kinnock did last week at the Select Committee, was describing the purpose of the MSF is to bring all the disparate elements together. So whether it's the data collection, whether it's the different types of funding, to actually stop what has happened in the past, which is a number of different elements. So if I may, we have some data. It is not consistent across the country, and none of us would say that the dashboards are consistent, nor to the level that is required to do the commissioning level of detail, which is why NHS England set out in their strategic framework. So that's the first point. The second point is that we're not saying that the MSF is the be-all and end-all, and that would be the wrong message that we want to give the committee. But what we are saying it is, and so Jim has reinforced, it is absolutely bringing together all the different elements, and it's crucial that we have the sector involved in putting that MSF together, and as Minister Kinnock said, be published later on in the year.
Well, that's a fair answer, but we heard from the previous panel that I don't know how many and I don't know how quickly, but there are certainly some hospices which are already running into financial difficulties and they're going to have to cut back their services. From what you're describing, and which is a perfectly logical, reasonable thing to do, it sounds as though that's going to take some while, if not years, to achieve. So how do the two things square?
The decision of funding allocation is that of course for ministers, and we've discussed in the committee, but they have said and have moved quickly to demonstrate commitment and their seriousness towards the hospice and the sector. I don't think that, and there is a difficulty in that hospices are not part of the NHS provision, but in terms of its importance, is what I said to Paulette right at the beginning. There is no question. I think the ministers have demonstrated that. It is an uncomfortable reality that hospices are charities and independent to the NHS, but it is not the only place that palliative and end-of-life care is provided. I think Ed has set out the different areas. So in summary, no question about the seriousness about which ministers are taking the sector. They've moved quickly. I think you've heard previously around the 125 million capital that was supported very quickly out to the sector so that the sector can actually decide what they want to do with it. And at the same time, because you would rightly hold me and others to account at some point in the future to say what are you actually doing to build the reality of what's going on where across the country so that we can do all the things that you're describing.
Reality is if a hospice has to reduce services or even cease performing its function, those will have to fall back on the NHS. So it is in the NHS's interest to keep these hospices going. Paulette, your question.
And I will follow straight on from Sir Gregory. And he's more or less asked the question that I was going to ask. So let me start by saying I absolutely appreciate that government and through yourselves have tried to support hospices, especially over the last 18 months. And over 125 million pounds has been given in capital to hospices. Now, I've taken on board the fact that you said what was said earlier by Toby, the chief exec, Toby Perkins. He made it absolutely clear that they have run out of time. There is no more rubber on the road. So what he's saying is in the next couple of months, they will be losing, I'm going to say staff, because when you lose services, as you know, in the health service, you're talking about your key commodity, which is staff. So my question is, how can hospices maintain the current levels of palliative care and provision while cutting services? And can I start with yourself, Sir James?
Yeah. So there is we're all in an uncomfortable position that we'll have to make savings right across the health service, as you've described, all very necessary because of where we've been and the overall financial position. In this specific instance, we would expect ICBs with local providers in the hospice sector to be identifying where anybody is, especially at risk of going out of business in the way that you've described. If that was clearly attributable to be an under-commissioning from the NHS, we'd expect people to resolve that locally, if that meant paying for something that should have been paid for, etc. I think probably, though, what we'll find is it's a general underlying fragility, changes in the charity sector over recent years, cost pressures, small providers that are probably unsustainable medium term. So again, there's a range of actions where you can see where maybe if people work together a bit more, they share some functions, they work as a collaborative, maybe there's a way through that. But none of us can guarantee nobody will go out of business in the circumstances that are existing now. You would again also expect ICBs, if they're in that position, to be able to do risk plans, understanding what would happen if there was a reduction in provision, and that alternative arrangements were put in place, with the NHS or through another system as well. All of that's happening and been happening. And again, when we're talking about the inconsistency nationally, the lack of clarity in terms of what's being bought across the service, there is, though, general quite good line of sight of what's going on in local systems, what's provided here and where, what would happen if something did get into trouble. And that's going on. People are talking and working through that. As of today, nobody's telling us that they are worried that someone's going to go out of business and it's a continuity of service problem that they would require help with. We can, out of this, just go around again and double check. We've got a session hopefully with ICB chief execs later on in the week about other things, and we'll pick it up there as well, and encourage a bit of a sweep on, where's the risk, what does that mean in terms of service provision.
So
we have got examples of when this has happened in the past, where hospices have started to go under. So Catherine House Hospice in Oxford in 2022 was really suffering from financial instability, and the local NHS trust was supported to move in and support service delivery while the hospice charity remained as a standalone charity, fundraising and continuing with those enhanced services, but the NHS Trust moved in to support the actual delivery of continuity of service. And so we've got examples we've learned from where we've managed to support hospices in difficulty. But the example before of hospices working across a patch as a collaborative is perhaps the most effective first stage for hospices, because some of those efficiencies around working in collaboration with others can come into play then.
So my next question, which is simply around that, because I always think that sometimes cutting services, if it's done in a professional way, and if you're looking at ways of cutting a service, but in a more quality service more than quantitative service. So my last point is, you are talking, well, you're not talking, but people are talking about cuts in services. How is it being measured that people will still get a high quality service when we are seeing that they are losing services, for the want of a better word, consistently at the moment within the system? I'll start with you.
So any big change like that, so big service change or a cost reduction or a change in commissioning would be subject to a quality impact assessment. So you'd expect locally colleagues to work through, if that happens, what's the risk, what would happen, how would you mitigate the risk, to try and prevent just an overall drop in standards and an impact on outcomes. So that happens in different parts of the system with any big change. In this specific change, if there was an issue where there was going to be a change in revenue flow to the hospice sector, that would potentially have that impact. Would expect the Commissioner to be doing a QIA as part of that process and assessing the risk.
So my final question, and I'm going to bring you in, Duncan, because you know I have to, because we're both nurses. So my question to yourself, Duncan, is, I worked in hospice services as a district nurse, so I went in and out. You know the way that system used to work. How are you ensuring that we are not losing that high quality of profession as we are losing and cutting services around hospice and palliative care?
Yeah, well, look, I mean, I think, and look, as I've said before, as a trustee of a hospice, this is really important to me. Getting care at the end of life is fundamental. It's a fundamental component of every nurse's role in this country. So it's really important that we get this right. I mean, I think there's several things here. One is about making sure that we've got the right numbers of staff in the right place, and actually that we are, as I said before, training staff to be able to work in community settings and exposing more staff to work in community settings. And I think part of that is actually about locally how well our nurse leaders are working together with their hospice equivalents, for example, in the trust. So when I was a chief nurse in a trust, I worked very closely with my hospices to make sure that, I supported them with rotations of staff, for example, because actually that kind of exposure between the two. And actually, one of the great things about the hospice that I work with is they've got a significant training offer out to the NHS, to social care, etc., to be able to provide those palliative and end-of-life care skills for as many staff as possible. So it's really important that we continue to do that. And as I said, we are developing a nursing and midwifery strategy for England at the moment, which will be out in the spring. And part of that will be around how we're going to educate, train, support nurses in the future. And I would expect that will absolutely lean into the fact that one of our core fundamental roles as nurses is making sure that we get good care at the end of life and better conversations about people towards their end of life as well.
Thank you for that. I'll hand back to the chair.
Thank you, Paulette. Thank you. Sarah Green, please.
Thank you, Chair. I just want to follow up on the conversation we've just been having, if I may address Sir Jim. It's in two parts. How much do we rely on independent hospices to deliver the palliative care provision in England? Are they mission critical? How would you describe that? And my second part of my question is, we've heard from Dr. Doyle how a previously failing hospital was supported in a previous example, given the April cliff edge, which was described to us by the previous panel, if a hospice was facing that cliff edge and did go under, how would you respond to that?
Mm-hmm. So they are material to the quality of service and is the key part of this system, key partner for us. It is inconceivable that we could function and deliver the standards that we need to deliver without them. So everything we're doing is about how we work together and introduce the better clarity. Everybody gets fairly rewarded, all those sorts of things. If there was a genuine example of a specific hospice that was going to go out of business within a period of time, as Amanda's pointed out, it's happened before. We've got some other issues going on with independent sector providers in other settings where that triggers a process locally and with NHS England where we'll look at what the alternatives are. Does that mean that the NHS has to and can step in? Is there another provider can step in? How would the money work? All coming from a perspective of continuity of service to try and avoid and mitigate the risk that the service does end up being significantly reduced.
Is this something that you're actively looking at right now, given what we've been told earlier? I mean, it sounds like it's a looming possibility.
As of today, nobody's communicated directly with me about a hospice that is close to going out of business. Not one. Okay. So I've heard of all of the concern. We're all concerned. I had a session with Hospice UK last week. I met with some hospice chief execs last week as well. So all are concerned about their financial sustainability. But as of today, there is not one single specific case that's been put to me that says this service is going to go out of business.
Thank you very much. Thank you, Chair.
Thank you, Sarah, very much. Clive.
To come on to the relationship between the money the NHS puts in to hospices and the charitable giving that funds many of them to varying degrees, and it's by no means obvious why different hospitals get different amounts of money, except perhaps to top up what they're getting from their charitable donations. So is that the approach essentially that happens now? A hospice keeps going as much as it can with its own donations, and then the NHS tops it up to make sure it can survive.
I think what we've all heard is there's a historical set of arrangements that they've sort of over time defined where the boundaries are, and over time defined what the NHS pays for and versus what's paid for through charitable donations. Ed and others have described that we would like to be in a position where we're more clear, we're more precise, that the NHS will buy these levels of service, and above that it can be funded, but it's funded through charitable donations or commercial sources or whatever. I think hand on heart now, Clive, at the minute that'll be largely historical, largely accidental, and there's all the consequences that people have described here, and not having the specific contracts and the data to support it with absolute clarity about what's being purchased where, commissioned where. None of us can be absolutely certain that that's consistent and uniform.
I think we can all agree with that. I mean, it's certainly difficult to explain logically why different funding is put into different hospices, but they do rely to different degrees on charitable donations. If those donations are being reduced significantly in some areas, we know the pressure on household finance at present. Is that a point where the NHS has to step in? Not because the hospice might actually close completely, but it might have to significantly reduce what it offers.
It goes back to the points earlier on about understanding what the implications would be, making an impact assessment of what would happen there, and if that was something that could not be allowed to change in terms of reduction of service because there was a disproportionate impact or an impact we couldn't cope with, we'd have to look at the alternatives, and whether that meant the NHS had to step in or had to be provided by other providers or whatever, that would be part of the consideration.
I think the aim is that for services which are clearly services that you would expect the NHS to commission, so specialist palliative care interventions, bed-based care, support to community services, we would be expecting ICBs to be moving to specifically commissioning that activity to a level that their population needs or to the level that the hospice can provide. We don't want to remove the ability, obviously, of hospices to go over and above and to provide some of the sort of therapies and additional services and support that they provide from their charitable funds. So it's important that what we do is accurately understand and count what NHS commission services, or what should be NHS commission, the hospices are providing, and contract for them and measure them and ensure that they're properly funded.
So I've written in the past about St Luke's Hospice in Sheffield. Does an absolutely wonderful job. The city's actually split in provision. There's the St Luke's, but then there's a palliative care unit at the Northern General Hospital. The St Luke's, they were clearly running at a financial deficit. I, along with other MP colleagues, wrote in support of them. So would I assume, therefore, that when extra funding was provided, not enough in my view, but a bit of extra funding to St Luke's, this analysis was done as to what they provide, and then the acute type of services, or the services that the NHS would require them to provide, were then funded on the basis of a new financial assessment. Was that done? Or should it have been done?
I don't know specifically what the ICB in South Yorkshire did in that case.
It might be helpful if someone could tell me, because if you're saying that's what should happen when a hospice gets into financial difficulties, it'd be nice to know whether it does happen or not.
Are you talking about the additional 125 million? Are you talking about the additional part, or just generally? Okay.
It should happen regardless of whether a hospice is in difficulty or not. So it's important that we move to understanding the data, commissioning services that we should be commissioning, and supporting and recognising that hospices want to provide services over and above all things which the NHS might not commission.
Be able to explain the continuing massive difference in grants that go to some hospices rather than others.
It's not being done consistently everywhere in all cases at the moment. I can find out about Sheffield.
Even within the same ICB.
Yeah, I can certainly find out how it was for St Luke's and right.
The differences there. Okay, just coming back to the over and above services that hospices might provide through charitable donations, and we come back to the equality issue. Doesn't that essentially mean that because you're going to always raise more money from charitable donations in more affluent areas, people who stay in a hospice in more affluent areas will always get a lot nicer surroundings, often to end their lives in?
Yes, Duncan.
Well, yeah, well, I was just going to say, look, well, one of the factors here is that clearly as charitables and independent charities, they have the ability to raise funds and find different methods of raising funds. And you're absolutely right. Look, I think as others have said, the hospice movement across this country didn't, happen in a linear way across the country, so that every area is served in the same way. But the reality is that there will be some hospices that will attract more funding because of the local population that they have and the ability to do that. But I think one of the important things then is actually for the challenge for some of those hospices is how do they help and support other hospices? How do they continue to develop in research areas, in education, and their offers to be able to provide support to others? And certainly working with a hospice myself, I've seen the work that they're doing to try and make sure that they are reaching all the different communities that they serve within those areas, and I know many are trying to do that.
Okay, it's a difficult one. It's about the difference between the provision of palliative care, end-of-life care in NHS properly in an NHS palliative unit, but they have much more difficulty raising charitable donations to the brand that a hospice can put out there to get them. Who wants to give money to the government in a way? It's slightly different. So, but aren't people in those units entitled to end their life in the same sort of surroundings as other people who probably just across the city in Sheffield are staying in a hospice?
Well, I think we would all sit here and say we would want the same level of palliative and end-of-life care for everyone. I would want that for my mum. I'd want it for any of my families. And I think this is why things such as the MSF are really important about how do we make sure we are commissioning in the right way, how do we make sure we're looking at the standards in the right way and delivering them. But I think it's also a fact that there will continue to be, where we've got a charitable system of hospices, there will be some that will be able to raise greater levels of funds than others.
Okay, I'll just come on to one other issue. It's the multi-year funding. Children's hospices have got multi-year funding, but adult hospices haven't. any organisation which is trying to plan, particularly one relying on charitable donations as well, needs a bit of certainty. Is it that difficult to give a multi-year settlement?
So again, part of the push that we've made on medium-term planning is to try and give people more certainty, more ability to plan over a period of time. So that's set off now, as we've described before. It's not where we are now, but every ICB has to produce a medium-term plan. Every provider in the NHS has to, and would expect people through this year to get more certainty as to how the next 2 or 3 years look after the year that we're just about to start. So it's the first time in, 7 or 8 years we've done multi-year planning. There's one thing that works against that. So as I'm describing that, is there's a push to be, for those providers to be paid more on a kind of tariff basis, a volume basis. There's an uncertainty with that. So if we're not going to be given block contracts and block grants, and it's more episodic and paid as per activity levels, there's an uncertainty and a risk there in income flows over time that we'll all have to work out how that gets managed together, because we can't have all things at the same time. We can give people reasonable assumptions about the future. Commissioners would give people this hospice sector confidence about what will be commissioned over a period of time, but there'll be fluctuations in volume, and income levels might go up and down according to that.
But if at least the hospice providers knew what those fluctuations would mean in terms of income, that would be helpful.
Yeah, absolutely. And that's what we're saying. We'll all work together and try and agree medium, but no one's going to say here's a guaranteed level of income block contract for 3 or 5 years that gives you absolute certainty without clarity about volumes, about what happens, whether quality's being delivered, etc., etc.
Okay, I get that. But when are we going to get some clarity on a multi-year basis about the tariff framework in which hospices operate?
I think we've answered that already. The MSF will be ready and live by about September. We'll try to build new financial mechanisms through the coming year. The NHS is in a medium-term planning process now. So all these things will come to life over the next 12 months.
So this financial year coming in April with the last year, when it's just a 1-year offer to hospices?
No, I'm not saying this. At any point will anybody get a cast iron guarantee that you're going to get 20 million quid for the next 3 years, etc. We're going to build all of these things, clarity on what good looks like, what the NHS should commission, some payment mechanisms. But what should happen, it should be happening now, but should definitely happen through the coming year, is ICBs working with the hospice sector, working with other NHS providers and other partners to provide a clarity of direction, what will be commissioned over time. So colleagues will be more certain that if they're delivering to the right standards within that framework, they're not providing things that aren't being commissioned, they'll have reasonable certainty.
So the framework that's operating in the next financial year will be a multi-year framework, will it?
The MSF, it was obviously going to be subject to Minister's approval, so that's the first thing to expect me to say. As Jim has said, that's what we are hoping, that the MSF will be able to bring it all together. I just want to give the slight caveat, obviously it is subject to that approval.
So if ministers approve, then the multi-year element will kick in from this April, subject of course to fluctuations in throughput of what the hospitals deal with. Yeah. Okay.
Okay, Tris, please.
Yeah, so I just want to pick up...
sorry, I'm out of order.
Matt.
I'm out of order. Matt, next. I'm so sorry.
That's right, Chair, no problem at all. Thank you. I should declare as well that prior to being elected, I was working in the health and care sector, mostly on the Better Care Fund and locality provision in Hertfordshire. The 10-year plan says community-based advice and support will help more people to die in their home, while community teams will work closely with care homes and paramedics to share care plans and avoid people being taken into A&E by default. Can you please tell me a little bit about what role hospices have in the community-based approach to care provision going forwards? Thank you.
So, hospices are a part of the neighbourhood services which will provide palliative and end-of-life care. And increasingly, the part hospices are playing is not the traditional just a bed base for people, but they're increasingly providing specialist palliative care support into wider community services, care homes, general practice. And in lots of places, the hospices are the providers of 24/7 palliative care support lines, advice and support lines. We would expect the shift away from hospital to make better use of those capabilities in hospices. It's really important as well that we don't forget the work that's happening around shared care records and better digitisation of services, because it's very clear that where hospices and community services and primary care particularly are able to view patients' records, see what interventions each of the staff has made, that provides a much more coordinated, better supported service for patients. And so it's really important that when an ICB is planning its shift out of hospital and its development of its neighbourhood health services, that every bit of the sector, including hospices, but including the wider voluntary sector, the people who provide night sitters, for example, to give respite to families who are looking after people at the end of life at home, and all of the wider sector are able to be part of that planning.
Thank you. And do you think that they're at a stage yet where they're ready and able to do that, or is that going to take a certain chunk of the 10 years?
So we are starting. So obviously everything can't change overnight, but we've given directions, I can't think of the word, but anyway, we've given guidance to ICBs in the medium-term planning guidance for 26-27 about where to start, and the patients at the end of life are one of the 2 priority cohorts of patients to start building integrated neighbourhood teams and start not only increasing the capacity in the community to look after people and support them, but to actually start developing that coordination of care. So the 2 priority cohorts are people at the end of life and people suffering from severe frailty. And obviously there's quite an overlap between those 2 cohorts.
Okay, great. Thank you.
Happy?
Yep. Unless anybody else wants to come in on that?
The only thing I'd say is, I think in a way, Hospice is ahead of the game. They did left shift before. I think it's only it's a give or take 20% of hospice beds are now inpatients. So hospices have innovated. They are innovators. When you talk to them, they are proper innovators, and they were ahead of the game, and they've done some of this already. And you get certain systems. I think it's Nottinghamshire where they've kind of got where they're kind of like part of the fabric of some of the kind of working really closely with the out of hospital. So I think it happens already in lots of areas. It's just not everywhere. So it's how do you support others to get to that place.
And I think have a really important role, and many places will do things such as provide support and education into care homes, and actually because that's those people's homes, and actually want to make sure that they're able to have a good death in care homes. So I think we can't underestimate the wider impact of their role in areas such as education and support to other parts of the sector as well.
That's great.
Thank you very much, Matt. Thank you, Chris.
Yes, so I picked up on your point earlier that you're not aware of hospices that are in financial, that you're not aware of any that are in financial distress.
So we're aware, and we've heard very clearly that every hospice provider is worried about financial sustainability. As of now, I have no specific cases that somebody an organisation is immediately at threat of going out of business.
Okay, and I appreciate that clarity, because part of this report shows really clearly, and I think Paulette mentioned this earlier, that in my view is a glaring red light that there is financial, it's not only financial sustainability, we're in a financial distress moment now. And if I'm using, quite a lot of hospices are actually closing beds down as we speak. They're announcing redundancies. Now, how can there be that I'm seeing in the news redundancies announced here, bed closures there, and yet you're telling me that those organisations are not in financial distress? Why would they be doing redundancy?
They're not in financial distress. I'm saying I'm not aware of any that are immediate threat.
My point to you, sir, is if they're doing redundancies and they're reducing their beds numbers, that to me would suggest that there is financial distress within those organisations because they're having to go through those processes. Redundancies, obviously, if they're expanding headcount, that would be because they're doing well or they're getting more finite. If they're reducing headcount and reducing beds. So my question to you is, have you analysed the hospice sector for financial resilience of those that you're partnering with and more broadly to identify what happens if there is a systemic, if one of these does collapse, what the impact will be in a particular area?
So as we're currently set up, ICBs would be responsible for that locally. There's a broader question at some point we'll talk about as we rebuild this system about economic regulation and sustainability of providers, generally NHS providers, independent sector providers, the charitable sector, any organisation that we're relying upon for continuity of service. So it's something we've started thinking about that as we start moving more into that sort of more market-based approach. But as of now, you would expect ICBs to be having some oversight in terms of what they're commissioning from the hospice sector. If changes are going to be made, as we discussed before, that could have an impact on service, to be an impact assessment. And as part of that, again, if there was a concern where an ICB thought this business is in distress, this organisation is in distress and we need to do something, I would expect to have a conversation about what would happen then.
So just lastly, just to follow up, in some areas, do you accept that the number of beds are reducing in certain parts of the country?
Yeah.
And given this report indicates that we are going to have an increasing demand, that, as Paulette highlighted earlier, we're in a situation right now where it's going, as of today, in the wrong direction, where we're seeing redundancies and bed closures and reductions in beds. Is that not telling you that the sector itself is fundamentally in a distressed position? And is there not more fear? Is there not a worry from you about that?
It is a worry, and we're not.
Whether there's a fear, if there's an acceptance that we're not in a good place at the moment.
Yeah, there's absolute acceptance that throughout we've agreed with pretty much everything that's been said. None of us want to be where we're at. We agree with pretty much everything that's been said in the report and in the discussion. But it's the position that we've inherited and have got now. We're trying to work through it over time. If there's a need to move quickly to resolve and fix a problem, we'll absolutely do that. But what we don't want to do is then perpetuate problems. Maybe support a provider that's delivering substandard care. So you'd have to expect that to be challenged. If there's alternatives around working together and getting scale, it might be that it's just subscale and it's actually not, it can't be sustainable. So you'd expect those sorts of things to be happening. What I would really want to emphasise is we would expect that to be an active process where all these things are being considered, rather than the NHS just sitting watching the capacity disappear and hospices go out of business. None of us want that. And if there's any evidence of that, if any member has a specific case that they want me to look into, I'll do that.
Yes, I mean, I can't, I'm just cautious of time, but just to summarise some of the cases that I've seen. So Prospect House in Swindon, Birmingham Hospice in Birmingham, St Giles in Lichfield. These are all individual cases where they've announced redundancies in the last 18 months and they closed inpatient beds. So those are just three examples around the country. Those are inpatient beds which are obviously now presumably going to have to be supported elsewhere within the system. As we heard earlier from our pre-panel, that is an additional cost which the NHS is having to bear. So it's not cost effective for us to see these beds closed, is it? If we can get the specifics, we'll go back to the ICBs and the system and get assurance that there's been an impact assessment, that people have considered what the impact would be and that there's alternative provision in place for the NHS provided elements of that. Okay, thank you, sir.
Anybody? Anna, you look as though you've got a question.
Yeah, I mean, we've talked quite a lot about the modern service framework, and I know Sam, you sort of said it's not the be-all and end-all, but clearly it is a very significant piece of policy development in this area. At the time the NAO reported it was slated for spring. Can I just confirm that I think, Sir Jim, you said September now?
Autumn.
Autumn.
Yeah.
Right, okay. Can we expect that there will also be clarity on the accountability for how are you going to monitor delivery against the modern service framework? Because we again heard from the pre-panel that there's no point writing another fancy framework that at the end of the day makes not a jot of difference to the fact that there's unmet need, inequalities in access, poor quality on the ground. So how are we going to make sure that it actually bites?
Yeah, so the MSF will have to have alongside it clarity on the oversight mechanisms, what we're expecting in terms of outcomes, what the metrics will be, how providers are overseen, how ICBs are overseen in terms of what they commission for all of this. So that'll all be part of the same package.
Part of it. Okay, yeah. Thank you very much, Chair.
So, Sir Jim, can I just, on point of clarification, if this MSF is not going to come out until the autumn, and it will take your ICBs time to alter their current commissioning arrangements away from grants towards contracts, as we've been talking about earlier this year, it effectively means, doesn't it, that no change will take place for a year from this April. In other words, into not the coming financial year, the following financial year after that. And in a sector that we know, I mean, we've got tons of evidence out here where beds are being lost, services are being lost. I would imagine by then a considerable number of more services will be lost. So what I'm getting, let me finish my question. I have to say I'm getting from this hearing a certain degree of complacency from that side of the table.
Honestly, that's really not the case. What we're describing is we're building things that will help in the future. We all acknowledge and are unhappy with where we are. There's absolutely no question about that. What we're describing is a process that will have to take place over a period of time to build the systems and the mechanisms to make this more sustainable and avoidable in future in terms of getting into this position. On the questions earlier on, there is then a more tactical day-to-day, how do ICBs and local systems solve problems as they arise whilst these new mechanisms are coming into place. So it's not a case that everything just stops and we'll wait for these things. It has to be actively managed in the meantime.
So are we going, just to put a practical step that you could operate from, the coming financial year, are you going to alter the way you commission from grants to contracts at the beginning of this coming financial year?
So I think we've said this a lot today, that we're trying to move away from block contracts, but ICBs are having to make a huge amount of changes in how the NHS is commissioned, and moving away from blocks, the unbundling of the block into new arrangements. If ICBs can make some of these steps more quickly, we absolutely will support them to do that. What none of us can commit to is that this happens quickly right across the NHS. But also, we'd absolutely be expecting ICBs to have read this report, to have listened to this discussion. We pick up with them specifically, understand the local circumstances, and be trying to manage the risk that's been described this afternoon.
But from April, what I see set out in the framework, in the planning guidance, I beg your pardon, is that from April, ICBs are absolutely required to have an understanding of their current and projected service utilisation, to actually understand what the demand is, and more importantly than just understanding it, being very clear about how they will meet that demand. So that is absolutely very clear from April onwards. And then the next bit on from that, of course, is how we're going to manage effectively. So I don't want you to think that, and certainly to support in terms of what Jim was saying, there's absolutely nothing happening, too many double negatives in that, between now and the MSF being published.
Right, well, we'll wait eagerly for that publication. I have to say, I think the position isn't entirely clear, even from this hearing today. I'd like to have a note, please, from you, very clearly, setting out how you're going to move, in what timescale, from grants to contracts, specific contracts for specific services that Dr. Scully was talking about, because I'm still not clear, as a result of this hearing, that I understand from your answers how that's going to work. So I would be grateful for that note, if we could have it in time so that we could produce, when we need to produce our report, which is in the next sort of couple of weeks, would be really helpful. So can I thank you all very much today for coming. It's not an easy subject, this, and we understand that there's always, at the end of money, there's always a sad person we're having to look after, and their family to support as well. That is inherent in this system. So thank you all very much today. We will be, a corrected version of the transcript will be coming out in the next few days, following which we will produce a report with recommendations, which we'll ask you to consider carefully. Thank you very much indeed. Order. Thank you.